My name is Rich Hawkins. I'm an orthopedic surgeon. This is Brett Harker. He's a professional baseball pitcher, and he's kindly offered to let us do an examination on his shoulder particularly, but other aspects as well. So we're just going to demonstrate some examination features. So first of all, in a normal exam, we put a patient through range of motion. I'm just going to stand behind Brett. So for normally, we go forward elevation, and then we do external rotation arm at the side. Notice they're equal. And then we do internal rotation up behind his back, hitchhiking thumb. And in fact, interestingly, he doesn't reach as far up on this side, and we'll demonstrate that in a moment. We come up in this position, which we're going to demonstrate supine for external rotation. You can see he comes back farther on his throwing side by a lot, maybe 20, 25 degrees. And then we do internal, not so easy here. Comes less on the right side than on the left side, which is normal for pitchers. But we're going to demonstrate these things more clearly as it relates to a throwing athlete. But if you'd be kind enough to come down here and face that. So we're going to look at the back of his shoulder. So we do similar things in terms of this. And I'm just going to come across. He's right-handed, so we're going to ask him to elevate his arm. And then we're going to come down slowly, Brett, like we did the other day. Keep coming, keep coming. So we're watching his scapula, keep coming and stop there. So this scapula is outwardly rotated a little more. Come on down a little more. And then you can see here how his scapula wings a little more, internal rotation, and down a little more. And usually it protracts a little more. So in throwers, they have increased protraction, upward tilting, and a little outward. And so in throwers in the scapula, if we look at this, we have internal rotation, external rotation, outward rotation, inward rotation, elevation up, elevation down, anterior tilting, posterior tilting, and protraction and retraction. So we look at all those aspects in a thrower, and you can see even his static position of his scapula is a little bit outward rotated. So rehab-wise, we'd certainly work on that extensively. So we demonstrated range of motion that we see in throwers, and we're going to demonstrate that supine, and then we demonstrated various aspects of the scapular examination, which is critically important. All throwers have some degree of scapular abnormality, those in trouble more than those not in trouble. But if we look at his throwing side, we do certain things. We look at an impingement sign on forced elevation, look to see if that hurts. Doesn't seem to hurt. So if we're doing that, then we come in the usual impingement sign straight across, and that hurts him. You can see right there. So he doesn't like that. And if we take him, this is scapular plane 30 degrees forward, coronal plane straight off, just back to the coronal plane, ask him to lift. And he seems pretty free there. We're going to ask him to push up. And he's strong, and that doesn't seem to hurt, and that's an impingement area as well. Having done that, then we look at certain other features in his shoulder. For example, does he have a slap tear? There are many tests for slap, but ones that we particularly like are O'Driscoll's shear, valgus shear test up high. So we take him up high and push back, and that's painful for him. So we think he does have a slap tear there. The other that we do for slaps is O'Brien's test, sort of 10 degrees internal rotation, thumb down, push up now, Brett, please, and try to break it down, and that hurts. We ask him where that hurts. Is that deep in his shoulder? So if it were superficial, then we look at AC joint and do crossed arm, but it's not, it's deep. So now we're going to do that test again, same position, 10 degrees in, thumb up this time, push up hard, and he's much stronger there and less pain. So that would be a positive flexion resistance test or O'Brien test for a slap. Those are two good ones. Supine, we also sort of rotate. Dr. Andrews likes to rotate, feeling for a clunk or a click. Actually, Brett showed us the other day, he took his arm on the wall like this, and he pushed back like this, and there was a fairly loud clunk coming from his shoulder. And I think his head was banging on that superior labrum. That would be our guess in that shoulder. And then we look, of course, at biceps involvement. So biceps is here. We see where he was tender generally in the shoulder. We would have done this, but AC joint not tender. If we put his arm just back, turn to the side a little. Codman's point is here, just anterior the acromion, and turn back again. And then biceps is sort of midway between axilla, lateral border, just distal, so about here, biceps. And not much tenderness there. The other good test for biceps groove tenderness is resistance in this position, make like you're throwing forward, And patients who have groove pain, often that hurts in the bicipital groove. And then finally we do what's called a speech test. We flex the elbow a little bit because we've ruptured actually 2 bicepses in patients in the office, believe it or not. One a nice university professor we had to operate on. Push up hard now, and then we look for biceps. Hardly any, if any, involvement of that. So does that hurt a little bit? Not at all. So that's a speech test. The other one's Jurgensen's, which is not very helpful, resisted supination. So we hardly do that particular one. So we've asked Brett to lay supine on the exam table, which is a critical part of what we want to do. We could normally examine the arm sort of in this position. We have a little device that sort of helps bring the arm in a little bit of the scapular plane, which I think most physios and shoulder thrower examiners think this is better. So we're going to look here, and we look for external rotation. And now in doing this, we're going to feel his coracoid and let him come back here. And when I feel that coracoid move is when we're going to document his external rotation. So it comes back, starts to move about there. So we're going to call that, what's that, Ellen? 115? Yes. 115. And then we're going to do internal rotation in the same position. And again, feel his coracoid and scapula, particularly coracoid. We'll take him down here till we feel it move. And I'm going to say about there. What's that now, Ellen? 28. We've already measured him up officially. Now the other thing we do when he's here is we're going to see if we push him back here how he feels with this. This is called a relocation test. And as we go back and back, see right there, that hurts. And you can really get fooled in how much extra rotation. But even if you look here, you can see his scapula move as I get him. But does that hurt you there?
It's not fun. Not
fun. So that's a pain. And then what we do is we put our arm on the upper arm, push back, and then try it again. And now, I'll let you see his face, but that hurts him much less. Yep. So that's a positive relocation test for pain. It does occur with apprehension, but we don't need to do it with apprehension because if you're apprehensive, you're pregnant, so to speak, if you pardon the analogy. So it really doesn't do anything other than reinforce that. But for pain, it's very important for internal impingement, a positive relocation test. The other test we do, excuse me, I'll just drop here, is we look here, and so if we rotate his shoulder, and he had that big clunk in there, Jimmy Andrews likes this test. I've not found it so great, but that'd be looking for a slap lesion as well. So that's sort of the supine examination we do. If a patient is up here, and I usually use my hand rather than that device, but if they're apprehensive here, then that's for anterior instability. Throwers don't get anterior instability because they don't recurrently dislocate their shoulder. It's really a different increased translational effect. Sometimes they get, that is the problem, but that's not really an instability manifestation if you think of it in terms of communication. Okay, so we're going to examine his other side, and I can do it from this side, but it's interesting because on this side, you remember he came how far on that one, Ellen?
He came 150.
So here we feel again his coracoid. So here he comes to 90. 90? And then we do the same thing internally, feeling his coracoid, and 45. So see, that's significantly similar arc on both sides, but very different amounts of external rotation, which is more, and internal rotation, which is less on the throwing side. Now we're also going to do translational testing, and I'm just going to walk in front of the camera, excuse me, but so if we do translational testing on this shoulder, we could feel for a sulcus sign by pulling down and putting my thumb in there to pull. He moves just a couple millimeters. Then we take the ball and we load it in the socket, push back, push back. Do you feel that slide a little? Yeah. It goes back a little bit. Does that happen to you? Do you sometimes feel it slide like that? He's nodding, you know. I'm not sure whether we believe him. Could be fibbing us. So that's a concern, but so that he only moves a small amount posteriorly. But what I did want to show, and I'm going to get down here, is now we load him again and push forward, and then, do you feel that slide? Mm-hmm. So anteriorly, he actually goes quite a bit. He goes almost to the rim, but not quite. Do you feel that when you throw sometimes that it slides like that? Yeah, so I think that's a little more believable for me in terms of which way. On this side, he's the same inferiorly and posteriorly, but if we take him here and just push forward, do you feel that slide?
Mm-hmm.
Is that as much?
Probably not as much.
Not as much, and that's my opinion too. Actually, he's going to surgery tomorrow, so we're going to examine very closely under anesthesia. So that's the translational testing we do, and whenever we translate someone and they translate, we ask them if that's their symptom complex. Throwers, it's a matter of determining whether they have any excess translation, because that's very meaningful. Now, we've already done retrotorsion studies on his shoulder, and he has 20 degrees more of retrotorsion on his throwing shoulder than he does on his non-throwing shoulder, which is really a lot. So that probably is pretty meaningful for his shoulder situation. So we've gone through our examination of range of motion, inspection for various things, and the scapula was the only abnormality that we saw in terms of static and dynamic. We didn't do strength testing, which we would do with range of motion. So we'll look at him. This is the coronal plane. 30 degrees off that is scapular plane. Sagittal plane is straight forward, and the frontal plane is just off the sagittal by about 20. That's the one we use for forward elevation. But we're going to assess his strength of scapula, supraspinatus, push up hard now, and then our response, I can't break them down actually, our responsibility is to do the other side and compare the two. We kids sometimes do that by standing here, you're good, and doing them together, push up hard. So interestingly, he's a little bit weaker on his non-throwing side, and our measurements would show that that was so, actually. So we also do external rotation with his arm at his side, and we compare the two sides. I can do this better from behind. So we'll get him in the advantageous position for external rotation. And he has the same external rotation he has here, but much more up here. So it's interesting. Push out hard. Pretty even. We can then do internal rotation, but pull in now against me. So disproportionately, throwers are much stronger with internal than external. And if we bring him up into this position, push back, we've already measured him up with our dynamometer without push against me here. This is more teres. Try this one. Push back hard. So this is the one, Chuck, that's weaker on this side. His teres is a little weaker here. So his infra is strong. Teres is a little weaker up there, interestingly. So those are sort of the strength testings we do. We could do forward elevation, but that's not probably necessary in a thrower. Okay, that's the strength aspect. Neurological exam is hardly applicable. We have a section for special tests in our exam routine. We've pretty much done everything in terms of slap signs, impingement signs, bicep signs, and so I think we've probably completed the picture. Vascular-wise, we look at his pulses and so on, and ask him to put your shoulders back and look to the left and feel if his pulse goes away, which it does not. Pitchers sometimes get into difficulties like that. Sometimes they get into acute difficulties with thrombosis. In terms of muscle atrophy, we see in throwers very rarely, but we look. But you can see his deltoid is good, trapezius is good. If we want to assess his pectoralis, sometimes we have to ask patients to resist pulling toward, and you can see here his pec, strong, just pull a little bit, and we can palpate it, so good pec. So then we turn him around and we look at the back, and he's right-handed. We particularly want to note if he has any wasting in his infraspinatus here. Looks pretty good. We think of a spinal granulomatosis cyst and a nerve involvement with that. And we look at his trapezius back here. And we look at the static position of a scapula, and we've gone over a scapula examination. Neck contour is good. The other thing we do is turn around this way. The other thing we do in throwers is we want to make sure we assess their core, so we mustn't forget that we throw from the ground up. But if we ask him just to lift up his right leg and then go up and down 10 times, now watch how good he is at this. This is a hip core strengthening test. Okay, and let's do it on your other one. So that would tell us his core and so on is probably pretty good, but we certainly start there with our rehab if necessary. Okay, good. And he works on core. What gives you your velocity? Where do you get velocity? You get it from your core, from down here. So he gets it from down here. That's classic. So we appreciate you doing that.